Well, thank you, everybody. Good afternoon, and thank you for tuning in. Welcome to our educational seminar with Stanford Healthcare ValleyCare. We're very excited to have them here today with great speakers. I would like to thank Stanford Healthcare ValleyCare for their support of the Dublin Chamber and all the Tri-Valley chambers in this series. In January, Pleasanton Chamber presented Heart Health, and in April, San Ramon Chamber presented a chat on emergency room versus urgent care. In June and July, Danville and Livermore Chambers will round out the series, so stay tuned for dates and topics. I will be posting this seminar on the Dublin Chamber of Commerce's YouTube channel if you want to refer back to what you've learned today or share with your family and friends. You may not know this, but May is National Stroke Awareness Month, and today we will hear about stroke. Rapid access to medical treatment oftentimes makes the difference between full recovery and a permanent disability. Knowing the signs of a stroke and acting fast, which I'm sure we will learn about today, is paramount when it comes to stroke. This topic is very important to me. I personally had a friend who had a stroke at work, and thanks to his fellow employees who knew the signs and symptoms and what to do, saved his life or avoided a life with devastating disability. So this is a near and dear topic for me. We have the Q&A function available for our audience, and we encourage everyone to ask questions. Today, we are joined by Megan Silvera. She is the Stroke and Neuroscience Coordinator for Stanford Healthcare ValleyCare and a co-presenter today. And Prashanth Krishnamohan, Medical Director for Neurosciences and Service Line. So without further ado, I'd like to go ahead and get started with our presenters today. Take it away.
Thank you so much for that introduction. Hello, everybody. My name is Megan. As mentioned, I am the stroke coordinator at the Stanford Healthcare ValleyCare site. We're really honored to be here with you guys today to discuss stroke, like she mentioned, the signs and symptoms, as well as some progress and growth in our neuroservice line. So just to kick us off here, we strive to achieve excellent patient care here at ValleyCare. Our goal is to bring the best of what Stanford medicine has to offer, but closer to everyone here in the Tri-Valley. And one of those big steps was becoming a stroke program. So we're a young program. We were Joint Commission certified as an advanced primary stroke center in 2019. We just got recertified last year, but we're growing and adapting and meeting the needs of our community. So we're going to talk about stroke. So why talk about stroke? In the US, someone has a stroke every 40 seconds. It's the third leading cause of death in California alone. The average age of a stroke patient is now 45, which is a lot younger than most people might think. And then only 22% of patients receive medical care within the necessary time to reduce complications. So again, we just want to bring awareness. That's what May is all about. So we're going to talk about more specific details of stroke. So what is a stroke? A stroke occurs when the blood supply is cut off to a part of the brain. And when this happens, that portion of the brain doesn't get the oxygen or the nutrients it needs. And the longer that blood flow is cut off to that portion of the brain, resulting brain cell death occurs, which is what leads to long-lasting neurological deficits if not treated. We often say time is brain, and that's kind of, again, that time portion of it that we need to act quickly and fast in order to treat and either reduce and remove further devastating effects of a stroke. So again, overall, stroke is the fifth leading cause of death in the United States, and almost 800,000 people annually have a new stroke. It's also the leading cause of disability in the United States. So again, it's just timely for everyone to get that and understand the signs and symptoms. So now that we know what a stroke is, let's talk about how we identify a stroke. So this is BFAST Bob, and this is who we use here at ValleyCare and Stanford and across the organization to teach patients, families, communities, staff about the signs and symptoms. And as we go through these symptoms, there's two key things to remember about stroke symptoms. It's an abrupt and a sudden onset of that symptom. It's not gradual, it just kind of happens. So we'll start with the B. B is for balance, sudden loss of balance and coordination. E is for eyes, sudden loss of vision. It can be in either one or both eyes, or sometimes you'll lose partial visual field. F is for face, the facial droop. That's kind of your typical smile for me, and they might have an uneven smile or drooping of one side of the face. A is for arms or legs. People may experience weakness or numbness or inability to completely move an arm or a leg. And with that, it's only going to be on one side of the body. So you might have weakness in your right arm and your right leg, but it will never cross and be right arm and left leg. So it's always one side of the body. And then S is for speech. Does their speech sound slurred? Are they having trouble finding their words? Anything along those lines. And then T is time, the most important factor. It's time to call 911. And a lot of times with time as well, we'll ask anybody who comes in with the patient, when was the last time they were seen normal? Because that, again, time is a key factor. And then more specifically, there's two types of strokes. There's your ischemic stroke, which is the most common type of stroke. 87% of strokes are ischemic, and this occurs when a blood vessel in the brain is suddenly blocked. That blockage can be caused by thick blood vessel walls or a blood clot that gets lodged in a blood vessel in the brain. And then there's hemorrhagic strokes. And this is a less common type of stroke, but a very devastating type. It occurs when a blood vessel in the brain bursts. That broken blood vessel can cause bleeding in the brain, and the area of bleeding doesn't have normal blood flow. So that area of the brain begins to die. There's also called mini strokes is what people refer to them. They're called transient ischemic attacks. We refer to them as TIAs. And a lot of times those are our temporary blockage that fall under the ischemic category and can be kind of a warning sign before a larger ischemic stroke. So we take them all very seriously, but they all do have the risk of having long-term deficits. And then risk factors. So the good thing is 4 out of 5 strokes are preventable. That's about 80% of strokes are preventable, which is huge. It's just a matter of knowing your risk factors and knowing if you can do anything about them. So with risk factors, there's 2 major categories. There's your modifiable and your non-modifiable. Your modifiable are risk factors that you can do something about. So your high blood pressure, smoking, diabetes, high cholesterol, obesity, physical inactivity. Being aware of any of those risk factors and having that discussion with your healthcare provider on what you can do to remove or reduce that risk. And then there's the non-modifiable, which is race, age, ethnicity, and genetics. But one thing we just like to promote is the lifestyle changes with your modifiable risk factors. So controlling weight, minimizing your total fat intake, physical activity, even walking, that also helps reduce high blood pressure, managing diabetes if you have it, and then smoking cessation as well. So we mentioned that we do treat strokes. Again, that time factor is significant. So for every minute that a stroke goes untreated, millions of those brain cells die. And for ischemic strokes, we can treat them. And that treatment window is 4.5 hours from the onset of symptoms. The sooner you get the treatment, the better. The gold standard for treatment of stroke is an IV thrombolytic. Previously, only alteplase or TPA was used to treat stroke, but there's a new medication. It's called tenecteplase. We refer to it as TNK, and that is it's a IV thrombolytic. It's faster. It's an IV push, and ValleyCare just switched to that in April. It delivers, it's just a 5-second bolus rather than an hour-long infusion, so it gets there faster. And there's been also multiple studies that show equal or higher incidence of reperfusion with tenecteplase, so that area of the brain that wasn't getting perfusion due to the clot is now getting perfused, and as well as it has a higher fibrin specificity, and what that means is it attacks that clot directly, so there's a slightly lower chance of a bleeding complication from it. For large clots that the IV thrombolytic can't treat, there's something called thrombectomy, and that's mechanical clot removal. And again, because we are partners with Stanford at Palo Alto, they are a thrombectomy capable center. So if a patient here were to have a large clot that were to be needed manual removal with that thrombectomy, we have the life flight ability, and we can fly them over to main campus to have that clot removed within a timely manner as well. So every 15 minutes that a patient receives treatment sooner, it decreases their risk of long-term morbidity and mortality. And so for every 15 minutes, 4 more lives are saved. Like we talked about that high prevalence of mortality from strokes. Every faster 15 minutes, 18 more patients are able to walk without any aid, and 7 more patients are able to be discharged home. So again, time is brain, that timely treatment really matters, and we're just happy we can provide that. So only 22% of strokes, receive the medical care in the time that they need in order to avoid or reduce those serious complications. So that's why we are proud to be where we're at as far as a stroke center, because on this map, being in ValleyCare, we're able to serve Dublin, Pleasanton, Livermore. Even we have a lot of patients who commute over through 580. So along the way, we're able to provide them timely treatment. Otherwise, the next closest center is San Ramon, Eden, or Washington Hospital. And as you guys know, Bay Area traffic can be a nightmare sometimes. So just having that access to our community around here, saving that 15 minutes, we're really able to save a lot of brain cells and provide a better outcome for our patients. And with that, I'm going to hand it over to Dr. Krishna Mohan. Dr. K.
Thanks, Megan. And thank you once again for having us here with you and giving us this opportunity. Megan spoke about sort of the stroke risk factors and sort of the overall stroke education. I wanted to focus a little bit more on what you can expect to see when you come here to ValleyCare, like what are the things we're doing in stroke, and even beyond stroke, what are we doing in neurosciences in general. So first, these are the 5 neurologists that we are here currently at ValleyCare. So if you walk into ValleyCare and for whatever reason, if you end up seeing a neurologist, you'll see one of us. And we all, even though we are all neurologists, we have within neurology, we have our own little sort of like subspecialization. So some of us do focused stroke or ICU, some of us do like more EEG and epilepsy based practice. So some of us do what we call general neurology. So it's a broad mix, and this number will continue to rise. We're looking to add more and more neurologists to the group. So in the coming year or so, you'll see like a lot more new providers come on board. So what are some of the unique things we're doing here within the neurosciences program at ValleyCare? Obviously, the first thing that we want to talk about and which we're really proud about is the stroke program that we have built. As Megan mentioned, we are a relatively young program. We developed the program sort of like in late 2018, almost like January 2019 or December 2018, and we got certified as a primary stroke center like in the fall of 2019. So very young program, but this was the biggest need at that time. There was, as Megan mentioned, we didn't have a good quality stroke program in the area, and so we identified it as a key priority. Now you will see as we speak about the stroke program and even the other aspects of neurosciences, we focused our efforts on 2 priorities. So one is we want to make sure that most of your care remains as close to home as possible. We just didn't want our patients in the community to have to commute 2 hours just to go see a doctor. And so we wanted to make sure we bring the care as close to home as possible. And more importantly, in the process of bringing these services close to home, we also want to make sure we still maintain the same high quality of care that can be expected of ValleyCare and Stanford Health System. And so we didn't want to compromise on the quality. And one of the things that we wanted to develop, again, most of the things that we're going to talk about, they're by no means necessary to be a primary stroke center. These were sort of our efforts that we took above and beyond to make sure we're not just checking boxes to get certified as a stroke program, but we want to make sure we actually deliver on the quality. And so one of the initiatives we had to undertake was, how do we make sure that all our stroke patients coming through our door actually have access to a stroke trained neurologist? As I said, we're all neurologists, but each one of us has our own sort of subspecialization. And while a stroke program technically doesn't need stroke neurologists 24/7, we made it a key priority that our patients be able to see a stroke neurologist, preferably in person, but even if not in person, we're able to provide the service sort of virtually through what we call telemedicine. So that little sort of computer-like thing you see on the screen on the picture, it's the what we call the telemedicine robot or the telemedicine card. And what it is it's basically a video form of evaluation, but the system is so well integrated within our own electronic medical records that the doctors at Palo Alto, even though they're not on site like at 2 in the morning on a Sunday, they're still able to access like all your images, like your labs and any information that they need to be able to make a determination about your treatment. And we're able to do this because we are one health system at Stanford. So we have well integrated health system. And then the camera that the system has is like really high resolution. So they can actually zoom in all the way to your eyelids or your pupils to make an assessment. And so it's as good as having a neurologist at the bedside examining you. And this was a key priority that we had, that we make sure that we provide access to stroke neurologists 24/7. And the other piece of technology that we had to acquire is what you see on this picture. It's called the perfusion scan or rapid imaging. And again, this by no means is a prerequisite to become a stroke center, but this was again our way of making sure that no matter which emergency room the patient walks into, you can walk into the emergency room at Palo Alto or the emergency room here in Pleasanton and ValleyCare with stroke symptoms, the testing and the workup we do is going to be the exact same across both facilities. And so that was the main reason we had to acquire this. And the reason this testing is important is, as Megan mentioned, there are two treatments to stroke. One is the IV clot busting medicine. And then the second one is where we have to take patients into the cath lab for a more advanced procedure where we try to go and pull the clot out. Now, the second procedure is not for everyone. There are some very strict criteria to identify these patients. We have to choose which patient actually benefits from this procedure because not everyone would benefit from this procedure. And this perfusion imaging is one of the ways for us to identify, or as we call triage, these patients. And so once we get the scan on our stroke patients, if we determine someone would benefit from this advanced procedure through the scanning, then these are the patients that we would fly over to Palo Alto to make sure they get the treatment that they need. All the other patients who don't qualify for this procedure, we would be able to admit them at ValleyCare and take care of them. So how has our stroke program really made an impact in this community? As you can see, we got certified as a primary stroke center back in the fall of 2019. And you can see like the rapid uptake in the number of stroke patients that we started treating as soon as we got certified. The estimates that we received before we became a primary stroke center were actually far lower than the actual volume we started to see. And I want to point out that between January 2020 and July of 2021, like the 18 months, sort of the first 18 months of the pandemic, when hospitals across the country were seeing a drop in their patient volumes, drop in their stroke volumes, drop in their heart attack patient volumes, we actually ended up seeing like over 400 stroke patients in those 18 months, which I think speaks a lot to the need for these services in this community, which we were totally under appreciating before we became a stroke center. And as you can see, like ever since we became a stroke program, year over year, our numbers have only continued to increase. Like there's just such a need in this area, and we're so glad that we're actually able to provide these services and make a difference in the community. And it's moving next slide. Yeah, thank you. So as I said, the patients that we identify for these advanced procedures, we fly them over to Stanford, Palo Alto for what we call thrombectomy procedure. And we are not the only site that sends patients over. Stanford receives patients from all across the Bay Area. And if you look at 2021, Stanford received like around 70 patients for this particular procedure, and more than half of them came from just our one site, from ValleyCare. That's how many patients we ended up identifying with these advanced imaging protocols and our stroke protocols, and more than half of them ended up coming from ValleyCare. And we treated like about 45 patients last year with this IV clot busting medicine, which are not small numbers for a community-based hospital. And it's not just numbers. We have definitely, as I said, it was a key priority that we do not compromise on the quality. And as you can see, even the short time that we've had the stroke program, we've had several awards, the Melinda Mitchell Award within Stanford Enterprise, and then the American Heart and Stroke Association Awards in 2020 and 2021 for maintaining our high level of quality that we strive for. Moving on. So one of the metrics that we closely watch, despite all the certification, all these awards, is what we call the door to needle. And what this is we look at the time from the second a patient walks through our emergency room door to when they actually receive this IV clot busting medicine. So the patients who qualify for this medicine, we look at when they walk through the door and how long it takes for them to get through our emergency room, for the physicians to see them, for them to get the scans, for us to do the labs, for the scans and labs to result, for the stroke neurologist to see them, make a treatment decision, order the medicine, for pharmacy to deliver the medicine, and then for us to give this medicine to the patient. As you can see, that's like about 10 to 12 steps we got to accomplish within like a short time frame. And the gold standard time frame we use is like we target 60 minutes. Now lately we've been pushing harder, we're pushing towards 45 minutes, but the widely accepted or the practiced guideline now is 60 minutes. And when we looked at in the first year of being a stroke program, we looked at how often we hit the 60 minutes. We were hitting it in over like half of our patients. And our median, as you can see, was like an hour and 8 minutes. And we are constantly working on cutting down this time, as for reasons Megan mentioned. With every 15 minutes we save, there's like a lot of benefit for an individual patient. And so we instituted quite a few changes. And if you look at our data in 2021, we were able to cut down this median time to 53 minutes, and we got over 60% of patients under 60 minutes. And as I said, our work doesn't stop here. We're constantly striving to improve our quality. And the new target we're setting ourselves is to consistently hit the 45-minute mark. And while that sounds simple, it's like shaving off a few minutes, you can imagine it's like 10 to 12 steps, and some of these steps have to happen sequential. Only if one step is done, we can go on to the next step. So we're literally talking saving like seconds to minutes in each step to make that difference. And considering that this is like a multidisciplinary team where we're like 8 to 10 providers from different departments involved, it's actually a lot of work, and we're hopeful that we will get there in the coming year or so. Next slide. Yeah, this is just another iteration of the same quality improvement that we're doing. This was just a few months sort of a pilot project we did where we were able to bring down the time almost down to 39 minutes. But the more long-term data, which was last year, we're currently at 53 minutes. Next slide. And most of what we have spoken previously with like the scan, the telemedicine, the door to needle, all of this happens in the first like hour or two. And as you can imagine, for patients, hardly they don't even remember that first hour or two because they're going through so much. They have a brain injury. There's so much commotion around. In reality, for most patients, only when they get home after the hospitalization, it hits them like what happened. They realize that they cannot get back to work. They realize they need help with even basic day-to-day activities. They realize they need help with showering, with eating. And so that's the time they actually need a lot more support, both medical, sort of physical, psychological support. And we realized these needs. And that's why we created our stroke support group. So we started this last fall. So this is a opportunity for all our stroke survivors to kind of meet other stroke survivors. And we'll also have like invited speakers from rehabilitation psychology, like physicians, kind of help them out during their recovery process. We have excellent rehabilitation services at our Livermore and Dublin facilities for patients to continue their stroke rehab even after they leave the hospital. And if they need to come back and see the doctor for whatever reason, we also have a stroke follow-up clinic. So we want to make sure that our patients have a good sort of experience through the entire spectrum of their illness and not just while they're in the hospital. Next slide. And while stroke program was our priority early on because of the big need, we've been also working on other aspects of neurosciences program. And one of the key interventions we did was in this, what we call the epilepsy or the EEG program. So for those of you, if you're not familiar with what an EEG is, the best way to think of it is if you're familiar with the EKG for the heart, where we put wires on your chest and measure the heart electrical activity. It's a similar thing for the brain, where we put wires on your head and monitor the brain waves. The reason this testing is important is many of our brain injured patients, be it stroke, like head injury from trauma, patients with cardiac arrest and brain injury, and patients with epilepsy who have seizures. For a lot of these patients, it's very critical to monitor these brain waves when they're acutely sick in the hospital, because oftentimes they have what we call silent seizures, where you don't clinically see them convulsing like you see in movies, but their brain just abnormally fires and they're just unconscious. They just don't wake up. And the EEG is a critical tool that we need to monitor these patients. Next slide. And the picture you see on the left, that's what we would call a conventional EEG, which is where we put like the 16 or so wires on your head. It takes a lot of time to put them on. We need a trained technician to put them on. It takes about 40 minutes to an hour to even hook up the patient. And then once the brain waves are monitored, it has to be sort of uploaded into a system where a trained neurologist can then take a look at these brain waves and then give a read. Now you can imagine this is a very resource intensive process, and you need like trained technicians, you need a lot of time to get this, and you need a trained neurologist to look at it. And it's getting so subspecialized where now not even any neurologist is comfortable reading it. We need neurologists who have additional training in EEG to read this. And so because of these limitations, what has happened is our ability to monitor patients on EEG continuously, meaning 24/7 in the hospital, has become limited to really these large academic centers. Smaller community hospitals are not able to provide this level of resources. So we got a little creative, and we sort of leveraged our relationship with Stanford to put together our Contingency program. And so what we do is, during the regular business hours, when we have our technicians available and the equipment available, we hook up our patients to this conventional EEG and leave them on if needed. We can also stop at 30 minutes, but most of our patients need this continuous monitoring. But if a patient comes in after hours, like at midnight or weekends, where we don't have all those resources, we use this device which is seen on the picture on the right. It's called Cerebellum. It's a much more handy device. As you can see, it's very quick. It's anybody can put it on with like 10 minutes training. I can train any one of you to put this on. So it's easy to put on. And the EEG, the brain waves, is recorded by that little cell phone like device you see on the pillow next to the patient's head. And it's not just records, it doesn't just record the brain waves. What the technology does is it converts the brain waves into audible sound waves. And so the idea being, any provider doesn't have to be a neurologist, an ED doc or an ICU doc who may not be familiar with interpreting brain waves. They can just listen to the sound waves, and seizures have some very characteristic sound pattern. And so in the middle of the night, when they don't have enough support around, they can quickly make these critical decisions in the middle of the night using this device. And in emergencies, this device works as a great complement to this full EEG device. Now, regardless of whether it's the full EEG or this cerebral device, the brain waves are then interpreted by our EEG trained neurologist, either at ValleyCare or remotely in Palo Alto. It's the same group that reads all our ICU studies at Palo Alto. So again, it's the same priority, whether the patient is here on EEG at ValleyCare or at Palo Alto on EEG, we provide the same level of service where these studies are interpreted by experts in their field. Next slide. So that was just some of the few things that we've been doing on the inpatient side. So what does the future hold? In neurosciences, we're still trying to grow. We realize there's like a critical gap in access on the outpatient side. There are not enough neurologists who are readily able to see patients in the clinic. We definitely realize this shortcoming. And so we have hired actually 3, this slide is a little outdated. We have 3 new neurologists who are going to be starting at ValleyCare over the next 6 to 7 months, starting in July until next January. We have 3 new neurologists who are going to be onboarded. And our goal is to have, even within neurosciences, multiple subspecialty representation. So the 3 neurologists are going to come on board. One of them is trained in multiple sclerosis. One of them is trained in what we call neuromuscular. So these are the doctors who take care of patients with myasthenia gravis, ALS, and sort of neuropathy and those sort of disorders. And the 3rd neurologist has a background training in epilepsy, so strictly seeing epilepsy patients. And our goal is, as we move forward in the years to come, we will have more and more subspecialties within neurology represented at ValleyCare. We also want to continue growing the support services, not just limit to stroke rehab, but continue this towards other conditions like epilepsy, for example, Parkinson's disease, bring on like driving simulation, which we are very close to bringing on, because these are services that a lot of our patients need. And being a part of Stanford, my patients ask all the time, do we have opportunities to participate in clinical trials? While we're not actively participating in clinical trials at this minute, there's a lot of work in the background to set up the research infrastructure. So we're hopeful in the years to come, we will have our patients will have the opportunity to participate in clinical trials. And finally, like to totally finish off the neurosciences service line, we obviously need neurosurgery services at some point. It's really like putting the building blocks in place to eventually be able to support neurosurgery. So these are the things which we are striving towards. And you'll see a lot of these things happening in the years to come. I think that might be all I had. Yeah, I'm happy to take any questions.
Thank you, Dr. K. This is Inga Houston here. We got one question already. Can a brain scan of my 60-year-old brain predict my chance of having a stroke?
Great question. So a brain scan in itself, when you don't have any symptoms, doesn't necessarily predict whether or not someone has will have a stroke. What it can do is it can give us some clues depending on the aging pattern and sort of things like that, to see if someone has a slightly higher preponderance in terms of risk factors. What is more important is for us to have your regular primary care doctor visits and the annual labs, which can look for all the risk factors, screen for diabetes, screen for high blood pressure, screen for cholesterol. If you're a smoker, like those are the risk factors that we can screen for. And those are probably your best predictors of having a stroke in the future, rather than actually getting a head scan.
I have a question. Can strokes be genetic if your parents had them?
So strokes can have genetic predisposition, but they're not necessarily familial. So there's a little bit of difference. So it's not something that's passed down from one generation to generation. So it's not necessarily familial, but there are a lot of patients who have they can have sort of like an inherent genetic predisposition to have strokes. We usually think of it when people start having strokes at a really young age, in their 30s and 40s. Then there's like some genetic reason why their blood tends to clot easily, or there's a problem with their blood vessels where they tend to block easily. But it's not common for it to be familial, but it can be genetic, yes.
Awesome. Okay, we have another question. Are indicators of stroke different for females and males?
The risk factors are more or less the same, but there are some inherent risks involved with certain gender in certain age groups. For example, because generally women tend to outlive men in terms of life expectancy, the overall incidence of stroke tends to be higher in women. That's just because they live longer, so there's higher incidence. But if you look at the stroke, like say in the age groups of 40 to 60, like it generally tends to be more male predominant. And then in certain phases of their life, for example, women, when they go through like their pregnancy and childbirth, or if they're taking like hormonal contraception, there are some of the risk factors that tends to increase a certain type of stroke in women, like the venous type of stroke, not the arterial stroke. We didn't talk a lot about it. So depending on what phase in life you are and like what gender, there are some variations to the stroke risk.
Okay, any other questions, guys? Get typing away.
There's
a few in the chat.
Oh, there's some in chat? Oh, they're in chat, not in Q&A. Sorry, guys. I missed those. I suffer from migraines. Am I in a high factor? Is my risk factor higher?
So generally not. Although a lot of migraine patients do have symptoms that resemble a stroke during a bad migraine attack, they're typically reversible. Now, there's this extremely rare, sort of like very small percentage of patients where they can have migraine associated with a slightly higher risk of stroke. But this is again where genetics comes in, and it's extremely rare, and it's an extremely small percentage of patients. For the vast majority of patients, what happens is when you experience migraines, you can have stroke-like symptoms, but that generally resolves as the headache goes away. So it's one of the common what we call stroke mimics. So I don't want anyone out with migraines out there to panic that they have a higher risk of stroke. It's not, even though symptoms can be scary, generally it resolves. But as I said, there's never a 0 and 100% in medicine. There is a very small percentage of migraine patients, because of genetic reasons, they can have a slightly higher incidence of stroke.
Awesome. Okay, thank you. Because I get migraines too. So thank you, Martha, for that question. If you are experiencing stroke symptoms, is it helpful to take too many aspirin?
I would recommend not, because unlike the research in cardiac heart attacks, we don't have much research in the stroke side to suggest that this is actually beneficial. And in fact, it may be detrimental, because we don't know when you're having stroke symptoms if you're having the clotting type of stroke or the bleeding type of stroke. And if you're having, for whatever reason, if you end up having a bleeding type of stroke and you take aspirin, there's this theoretical risk of us making that bleeding worse, because aspirin obviously tends to keep the blood thin. So we would recommend not taking anything if you experience stroke symptom, but just to call 911 and get to the hospital. The second reason we don't want you to do that is oftentimes when patients experiencing stroke symptoms, your swallow function is impaired. Many types of strokes impair your swallow function, and patients are at extremely high risk of aspirating and developing pneumonia. And so if you try to take some medicines, drink water and things like that, we could inadvertently cause aspiration and develop pneumonia and other complications. In fact, it's a strict protocol of ours where if a patient comes in with stroke symptoms, we don't let them eat anything by mouth until our nurses or our swallow therapists are actually able to check their swallowing and make sure they're safe to swallow. So I would say no to that question.
Good reasons. Good reasons. Are ocular migraines indicators of stroke? And then,
yeah, it's not. Again, oftentimes stroke symptoms and migraine symptoms tend to overlap, so sometimes it's hard to say upfront what they are. But if you truly have migraines and if these episodes have been determined to be migraines, then they're not necessarily risk factors or indicators for stroke. The symptoms would resolve.
Are there any more questions? Oh, I'm getting lots of thank you for explaining that. I think that was for the mini migraine, or the mini aspirin, mini migraine. Anybody else have any questions? No? Oh, excellent presentation. Thank you, Kathy, or Stu, I'm not sure who. Awesome. Well, I know strokes coming in when you're younger and younger, that seems to be what could cause it happening younger, because I always thought it as being, in the 60-year-old range.
Yeah, so it's been a phenomenon that's happening across both stroke and cardiovascular health. We don't understand them fully. Typically, we think of stroke as a disease of aging, and even now I think if you look at the overall numbers, it's still like primarily in your 6th and 7th decades, but we do notice that there are younger patients coming in more and more. We don't have, I think it's more a multifactorial thing. I don't think it's like one clear reason we can point out. Definitely like the lifestyle and the sedentary lifestyle with the current environment and the risk factors, which a lot of them accumulate because of sedentary lifestyle. And I'm sure there's more to it, like epigenetics and stuff. Again, we don't fully understand, and I don't think there's like a single reason we can point our fingers at. As we consider like risk factors for stroke as sort of like modifiable and the non-modifiable. So the modifiable risk factors are what we spoke about, is like your diabetes and high blood pressure, smoking, cholesterol, sedentary lifestyle. Those are things you can sort of modify and try to reduce the risk. But then there are a lot of these non-modifiable risk factors, which unfortunately we don't have a great control over. Things like aging, right? Like things like gender, racial or ethnicity. If you're a certain race, certain ethnicity, there's a slightly higher risk of strokes. So these genetics, so these are all things which we unfortunately cannot control. And for any given patient, if they have a stroke, it's generally a combination of modifiable and non-modifiable risk factors. It's like cancer. You can never like point your finger at one cause and say this is the reason something happened.
Okay, is stroke greater in the United States than it is elsewhere in the world? Do you know that information, or?
I don't think it's the leading or the number one incidence of stroke in the world. There are definitely like other countries. For example, like Asians and Southeast Asians also have a fairly high incidence of stroke. So I don't know that I have global statistic to say which country is like the number one to say. Here in the US, at least, we identify certain areas where there's an extremely high incidence of stroke, and we are in a not that much of a high risk. There are like other parts of the US, like we call it the stroke belt across the Midwest and South, where there's like a really high incidence of stroke, and we see a lot more incidence of stroke in young patients in their 30s and 40s.
Wow.
And it's primarily a combination of all these risk factors. Like there's very uncontrolled risk factors. The part of the West Coast we live in, we are a relatively better shape from a stroke statistics perspective. Most of the stroke patients we see are in their 7th and 8th decades, and most of it is like the non-modifiable risk factor, which we unfortunately can't do much about.
So California, keep on walking, keep on eating well.
Yep. Keep on the hiking and the biking. I think we'll do good.
There you go. We got that going for us. Great weather and pretty scenery, reasons to get out. Just don't play too many video games, right? Or work too much on your computer. Are there any other questions?
There's one in the Q&A.
Oh, there is. Okay, I'm sorry, I missed that. Do symptoms vary depending on the type of stroke? Blockage or the hemorrhagic? I can't say them.
Yeah, if it's no. So typically stroke symptoms, it's very hard to say based on symptoms, whether you're having a blockage or the bleeding type of stroke, because in both cases, either because there's a blockage or a blood vessel ruptures, a certain part of the brain doesn't work well. So what we're seeing externally is that you lose function of some aspect of your body, right? Like your arm doesn't work or your legs don't work, you can't speak or you can't see. And so regardless of what the underlying problem is, whether it's bleeding or clotting, the symptoms on the outside look exactly the same. And even as a stroke trained doctor, I cannot say the difference until I look at a scan. We need a CAT scan at the minimum to kind of make out the difference between the two.
How long does it take to get a CAT scan done?
The time on the scanner is like about like a couple of minutes. That's the scanning time for like the plain, what we call the CAT scan without contrast. But because of the things I mentioned earlier, where we run some additional sequences to triage these patients for like advanced treatments, our stroke scans take about roughly around 15 minutes on the table. To complete all the different scans. But generally, if you're just looking at a non-contrast head scan, which is like the minimum requirement for a stroke center, it's like only a couple of minutes on the table.
Okay, because that 15 minutes is important.
Yep.
Now a blockage type stroke, that can happen after surgery or something like that, or as a blockage type stroke, or is a blockage or more susceptible in the lungs or the heart after that, like blood clot.
So the blood clot in the lungs is a slightly different problem than the blood clot in the brain causing strokes, because one is on what we call the arterial side, which is the brain strokes, whereas the blood clot in the lung is usually on the venous side, the veins. So they're slightly different. But to answer your first question, going back to surgeries, so there are some surgeries which are inherently higher risk for patients to have a stroke as part of the surgery, unfortunately. Any type of like heart surgery, for the most part, where you go on this bypass machine or the pump, as we call it, that's an extremely high risk scenario. And even in the with the best surgeon, best equipment, everything is great, there's still an inherent risk. It's not anyone's fault. It just is a part of the problem. And then there are certain types of other surgeries on the aorta, the blood vessels in your chest or the blood vessels in your neck, the carotid surgeries. Those are again high risk procedures for patients to have stroke. So this is directly related to surgery. Now, oftentimes unrelated to the type of surgery, what can happen is if you're on, like, say, medicines like blood thinners for AFib, for example, people take Eliquis or warfarin, Coumadin, whatnot for their heart. Before any of these medical procedures or surgeries, doctors typically ask you to stop the medicines So you don't have a lot of blood loss during the surgery, right? This can be unrelated, like a knee joint replacement surgery. We still have to stop these medicines. So anytime we stop these medicines for surgeries, then indirectly it elevates your risk of stroke, because you were taking these medicines for a reason, to prevent the blood from clotting. And so now that you stop the medicine for the surgery, we hypothetically increase the risk of blood clotting off at some place. And one of the places can be the brain, and it can cause a stroke. So surgeries do increase your risk both directly and indirectly, depending on the type of surgery and the medications.
Stay healthy. As much as you can. I don't know if you can see in the chat, there's lots of great feedback for the programs, and we're looking forward to the next ones with Livermore and Danville. I don't know, Shelby, maybe you can tell us what they're doing, and if there's any more questions, this is your last chance, guys.
Thank you so much, Inga. Yeah, the Danville presentation is going to be focused on latest updates that are occurring at the organization. Lots of new services are coming and or expanding. So just some great things for the community. Our CEO, Rick Shumway, is going to present there. And then Livermore will finish off the series this summer. We'll be promoting a date soon, but they are going to be focused on skin cancer and sun safety. So really important topic as we come into the summer. So thank you so much, both Megan and Dr. K. We really appreciate your time today on this series, and for everybody joining today. Thank you so much.
Our pleasure. Thank you for having us.
Thank you so much. We really appreciate your time and Stanford's support of the chambers here in the Tri-Valley.
Absolutely. Have a great day, and thank you, Inga, for Dublin's support, of course, as always.
Absolutely.